Very good morning, everybody. Today, I will discuss a very important and interesting topic, antenatal care. It literally means the care of the pregnant mother. That is called antenatal care. But it covers the wide spectrum of subjects. It is not only the care, it is the supervision of the mother. That is the most important, supervision of the mother when she becomes pregnant, and routine management of the mother, pregnant mother, but she takes special care. And all of you know, the pregnancy, there may be some complications like hypertension, antepartum hemorrhage. So detect any complication early. Detect any complication early. And even to prevent that complication by some management, we can prevent the complication. We anticipate these are maybe the complications. So, the supervision throughout the pregnancy, the routine management, and prevention of any complication, and management by early detection if there is any complication. So that I will elaborate. Antenatal care, the concept of the antenatal care is that it came the end of the 19th century, but organized way, it is the beginning of the 20th century, the antenatal care started. And pregnancy is always a high risk, potentially high risk. Previously it was said the antenatal care is sufficient for the management of the pregnant mother. But later, particularly the end of the 20th century, it was said it is not like that. If everything goes on at the time of, till the time of delivery, there unexpected problems may occur, complications. That has been addressed, the emergency obstetric care. So that is the two part of the, that is called emergency obstetric care, and that has been defined and has been stressed in the beginning, at the beginning of this century, the running century, the 2003 actually. So as it is we are this class, antenatal care, I think all of you read in preventive and community medicine, same community medicine. But you are going to be a clinician. So I will discuss one by one so that stressing on the clinical aspects, something of the clinical aspects. Now, so it is the basic definition. Small definition. Antenatal care is the periodical and regular supervision and care of the. Okay? Periodical supervision and regular supervision and care. Routine care and if there is emergency there. So what is the aim? What is the aim of the antenatal care? What is aim? To prevent and to detect any abnormality at the earliest possible time, I have already said. And second, the primary aim is there, which is to achieve a healthy mother and healthy body at the end of the delivery. Our achievement. Because all of you know the maternal mortality, that is the MMR, is India is still 100 per 1 lakh by birth, average 130 like that. It is changing, reducing gradually. And but in the developed country, it is only one figure. It's like 5 to 6 per 1 lakh like that. But when we are the student like you and also the registrar, at that time it was about near about 1000 1 lakh like birth, MMR. But it has been reduced by the proper antenatal care and the obstetric management and emergency obstetric care. It has been reduced. And we are sure the sustainable development goal, sustainable development goal, which is up to the 2030, yes, we will achieve the target, particularly India and also West Bengal, achieve the target of the 70 per 1 lakh live birth, MMR. These what I am saying, the statistics is very important for all of your exam purpose, MCQ or like that everything. So who introduced first? It is the J.W. Valentine. He published his plea for a pro-maternity hospital in the year 1901. When should be the first antenatal visit? That is very important. When should be the first antenatal visit? It is definitely as early as possible. And the patient says, and most important and commonest symptom is the amenorrhea. It is normally married women trying for pregnancy. That is the amenorrhea. And there will be some symptoms, there will be test. Sometimes as now the pregnancy test, urinary pregnancy test is easily available, many patients, many couples will come with the pregnancy test. So when should be first antenatal visit? That is as early as possible, 18 to 12 weeks. It is preferable that. It is preferable that during the first trimester, she come first, whereas before 12 weeks, preferable. And what should be the minimum checkup, minimum antenatal visit, minimum number? That is a very important question. Minimum number of checkup. It was traditionally said at least 4 checkups, at least 4 checkups. That is called the booked case. Traditionally, at least, because there are so many people lies, majority of the people lies in the rural area where health service is not till available in very organized fashion. Now, almost the government has trying to reach the periphery, particularly from one of the important issue in the health is the maternal health. And first is the booking visit. You see 12 weeks, that is the first trimester. Second, 14 to 26 weeks, that is the second trimester. And third at the 28 to 32 weeks. And fourth at the 36-34 weeks. Why 28 to 32 weeks? In fact, it has been found the common complications arise after that time. Suppose you know the preeclampsia, the hypertensive disorder, and also sometimes the blood sugar, gestational diabetes also appear from late second trimester or third trimester, and also antepartum hemorrhage, abnormal presentations all appear. So this is the 4. But now it is said by WHO guideline is that at least 8. They said not the antenatal visit, they said the antenatal contact. Why contact? Antenatal visit means the patient, the mother couple will come to the facility. But contact means any health worker, because all of you know from the community medicine, the health workers work in the periphery, and there is a sub-center also, there is a sub-center. The health worker female health worker will visit the room and give a contact. Total 8 contacts. And where should be the 8 contacts? These are the 8 contacts. So it is said, if you asked in exam, what is booked case? Booked case, what is booked case? You say at least 4 is called the booked case. So this is very important. Now, what is the composition of the antenatal care? Composition, what should it embrace all the things? Many things. Many things. You see the detailed history taking. As it is a medical MBBS teaching, history taking, you know, in exam also there is the history taking, obstetric case you will get. That is the history taking is important. Maternal history taking. Her age, because the elderly age, there is complication. There is teenage pregnancy, complication. So age and where does it stay? If you stay from long distances, that is their impact. That is the impact. But he will not come in emergency. And the obstetric history, particularly now any problem because the amenorrhea and other any problem of this pregnancy. And the second is the past obstetric history, because past obstetric history, suppose she has one dead child, she has delivered a dead child or like that, or any past obstetric history. I will go in detail, that is important. And LMP and EDD, menstrual history, and also the medical history. Medical means the past medical history, like she is suffering from heart disease, heart disease, and any surgery, only drug history she is taking. So that details I have not described today, but the history taking that will need in your obstetric case taking, in OPD and also in the clinics, you will go. That is very important. Next is the physical examination. Thoroughly physical examination it should be done in the first antenatal visit, not after, not all the things in the repeated visit, but a thoroughly physical examination. I will point to and the obstetrical examination. You know, obstetrical examination, in any obstetrical examination is included, that is the best examination, because the lactation is the important thing throughout the maternal and child health care, lactation. The breast, if there is a retracted nipple, there will be a problem during the lactation. The breast examination, and second is the per abdomen examination, obstetric, you know the grip, the inspection, palpation, auscultation, and per vaginal examination. Per vaginal examination is not a routine process, but one examination is done for taking the pap smear and any abnormality is like that. Now next is the baseline investigation. This is a very, very important question in your MBBS curriculum. What investigations you will advise? What investigation you will advise during any antenatal mother? I will come to that. That is, you must know what is the hemoglobin concentration, what is the grouping, ABO grouping and RH, because RH negative mother, there is a chance that in the second pregnancy, there may be the baby with the hemolytic disease. So you will have to prevent. That is the one miracle in the obstetrics, medical science. There antiglobulin is given to the mother, so there will be the subsequent babies will be protected, RH negative mother. And also the study like the VDRL, PPT-CT-IT, hepatitis B surface antigen. Hepatitis B surface antigen is very important, because if a mother becomes hepatitis B surface antigen, there is every chance that their baby may be affected. So at the time of the delivery, now it is a routine, the hepatitis B injection will be given, active and passive immunization to the neonate to protect the future, because no, hepatitis B causes many liver diseases, even the carcinoma, so the baby will be protected. It is one of the another discovery. And antenatal advices, that is very important. So these are the components. That is the very Important thing, routine investigation, I have already said. You see the routine investigations. Number one is the blood investigation. The hemoglobin percentage and complete blood count. You see the complete blood count. And ABO grouping and the RH factor. And the blood VDRL, the screening for syphilis. And next is the immune examinations for protein. This is very important because the protein appears particularly after 20 weeks, there may be chance that there will be patient, the hypertension with proteinuria, chance of preeclampsia. You know, all of you know, the preeclampsia, that is the hypertension, proteinuria and other organic damage. Preeclampsia, 140 and or 90, more than 140 and or 90. Blood pressure developing after 20 weeks with proteinuria and also some other organic involvement. That is the preeclampsia. So proteinuria is a very simple thing, urine examination. And blood glucose examination. Blood glucose examination you will have to do only in India, but not always, because India is a country with the high diabetic incidence. That is blood glucose is universal screening. There are some guidelines in the other countries, they don't do the blood glucose on all patients, only high risk patients. But India, universal screening. And HIV testing, a must. And hepatitis B surface antigen, and also the cervical smear for pap smear. If you know, the cancer cervix one of the important cause of death in India, throughout the world, but India. Why? There is no screening, but cancer cervix is a disease which takes a long time to develop, about 15 years like that, if the HPV infection is there. So pap smear you can see whether there is abnormal cell, and all of you know there is the injection, the HPV vaccination, and all of you know about the HPV vaccination, and this age and it is also the male carcinoma, also some type of carcinoma, HPV vaccination. All of you should take the HPV injection. This is not related with my topics, but HPV injection, it prevents the cancer and definitely HPV injection. Hepatitis and the stool for routine examination, and ESG for fetal-placental profile. ESG for fetal profile. ESG, that is a very important question. I will give you the stress because you have to read the book, you do not know which is important, which is less important. That is what ESG in your antenatal clinic after passing you will do, when ESG you will do, and what information you can get. Now, other specific investigation, this is not recommended routinely, but in clinical practice you should do rubella. Rubella, whatever you know, the rubella is a disease, that the congenital deepness of the baby, rubella, if the rubella occurs during the pregnancy. The MMR is the universal immunization program that will prevent the rubella. So that antibody, sometimes the patient may not take the rubella injection or there may be failure. So we will do the rubella antibody. It is not routine. But I do actually. You should do. You cannot give the rubella injection during the pregnancy. At least you know the mother will not go any area where there is a chance of rubella infection. Get it there. And thalassemia screening, you know, the thalassemia screening you should know whether the thalassemia minor, if the thalassemia minor, and she is married to another thalassemia minor, the baby may be major. There may be chance of the major cases. That is because thalassemia minor, nothing actually there is symptomatic. Only thing the hemoglobin level is slight low, thalassemia minor. So that is for instance, if there is a thalassemia minor, if there is a HPLC screening, and then you screen the baby also, in the husband also, whether the minor or not. And then you will have to investigate with the baby. Now, the modern obstetrics and modern antenatal care, you will be able to know. And thyroid screening. And thyroid screening, I say, it is a very silent disease. You do not know thyroid. If a mother becomes pregnant, when there is a high TSH level, that is my thyroid deficiency, that there will be strong effect, other than the mother, there will be strong effect of the baby. Because baby's thyroid gland, it will form at 20 weeks, it starts to form the 12 weeks. But thyroid hormones has a great role in development of the intellectual. And that will be completed almost the brain with that first trimester is important. That is, it should be routine, not universal recommended by the India, but it should be, TSH should be 2.5 unit pre-pregnancy level, 2.5. And combined test, this is the modern test. Combined test mean the at 11 to 13 weeks, that is the first trimester FCV, you do USG. If you show there is NT thickness, not NT thickness, when nuclear translucent thickness is 3 or more, and there is a biochemical test positive, the dual test, there is a screening test. There may be chance of the aneuploidy. This is called aneuploidy. But it is not that they are suffering from the aneuploidy. Then you will do the other test. This is very important. The combined test USG and the screening test for aneuploidy, Down syndrome, trisomy 18, trisomy 17. Down syndrome survive for a long time, Down syndrome. If you see the Down syndrome in pediatrics, you will see in Down syndrome, there is a very pathetic condition, Down syndrome. They will survive whole life. So that is this you screen and on diagnosis there. So these are the should be learned, not routine. This combined test, it is must now. It is must now, combined test. All things should be done, and gradually the government of India come into the free of cost everything gradually and you will see thing. How does USG? It is important. The first trimester USG how it does it here. That's the important thing. First trimester USG. And when you will do first trimester USG, you can diagnose the pregnancy. When a patient comes, infertility patient comes for treatment to me, for social reason and with the pink color positive, a social reason, I say don't disclose now until and unless you get a viable baby in the intrauterine cavity, because that baby was missed abortion, blighted ovum. So diagnose the intrauterine pregnancy important, and sometimes you say there is a pregnancy positive, but there will be the missed abortion. There is no cardiac ultrasound, and cardiac ultrasound you can get in about 6 weeks of pregnancy transabdominally, 6 weeks, and earlier in the transvaginal, and that is important. And and another thing is the ectopic pregnancy. In ectopic pregnancy also, there are many the positive pregnancy positive. So that is which was important in diagnosis. And other thing is that to determine the gestational age. Gestational age is the early ultrasonography, the crown of depth in suppose she cannot say the LMP, or later weeks, the 20, 30 weeks of pregnancy, she came to you, and you will see the period of area not correlated with the height of the uterus. So what will you do? Then you will see what is the age from calculating from the earlier test, from calculating the crown only, and later on in that is only the head circumference and 14 to 20. And after that, many other things are done, the fetal profile. And to exclude the multiple pregnancy and to detect any pelvic pathology, suppose ovarian tumor, fibroid uterus, or uterine anomaly. So this is very important thing. For short note, the USG finding in the first trimester, not to diagnose pregnancy, not to diagnose the intrauterine. Some exclude things, multiple pregnancy, exclude things like blighted ovum, ectopic pregnancy, and also the crown lump measurements is important. So it should be done as in the first trimester. And another is that is the aneuploidy scan. I have seen aneuploidy scan. In 11 to 13 weeks, you do the nuclear transparency. This is the fetus and this is the NT. If the NT is more, there is the screening test, not the diagnosis test. There is a chance of the aneuploidy, and biochemical marker is also changed, and the risk of combined test. And diagnosis of some gross structural abnormality. Usually the structural abnormality is best diagnosed, the anomaly is 20 to 20 weeks, another 20 or after that. But some structural abnormality like the anencephaly encephalocele can be diagnosed earlier, can you suspect that baby. So that is the importance of the 11 to 13. So one USC is 11 to 13 or 11 to 14 weeks. That is very important. And mid-pregnancy scan, this is also you will do. You are practicing obstetric practice, and suppose in 32 weeks you see that there is a case of the gross malformation of the fetus. There is a gross malformation of the fetus. That is why the patient relatives and party will show, sir, my gross malformation you have not informed me. The gross information of the fetus, and whole life will have to live with her. You will hurt your relatives. There are so many incidences there. So that is the anomaly scan. Majority of the anomaly can be diagnosed within 22 weeks. So anomaly can be done 20 to 22 weeks. Why more than the 22 weeks? You know the MTP rule 2022 permits the MTP within 24 weeks. Recent, before it was 20 weeks. If there is a only gross anomaly, you can do the MTP. So why there is a very anomalous baby will allow to be born in earth, anomalous baby, because the trouble of the society, trouble of the family. So gross anomalous baby, 20 to 20, that is also very important. Also at that time, you see the length of the cervix. If the length of the cervix is short, there is a chance of preterm labor. You can predict. And also the placental localization. Placental localization from the early pregnancy you can see. But more in case of the 20, if the placenta is the lower retention, what is the result? Lower retention segment, that means what they are there? Placenta previa. Placenta previa, that is the placenta previa. That there may be antepartum hemorrhage, two antepartum hemorrhage caused in the placenta previa and abdominal placenta previa. So that is the mid-trimester scan or anomaly scan. So ultrasound is a very important information. And other ultrasound recommended one between 11 to 12 weeks and another is the 18 to 20 weeks, anomaly scan. And combined test, biochemical and sonography, that is the biochemical is the PAP A and serum beta ECG. These are that type. Biochemical I am saying with not only ultrasound, also the PAP A, the dual test. And other ESG, if you do other ESG, you will show many doctors say they do the other ESG according to the need. ESG 1 you can do at the 28, 32 weeks of pregnancy, and if the situation arises, out of there may be suspecting growth restriction or any other problem, you see, then you will do for growth profile, the growth, whether the fetus is growing well or not. So according to the condition, you will see. And hemoglobin repeat test, the following, there are, you know, at least 4 or 8 WHO, they repeat the hemoglobin at 20 weeks of pregnancy because there is the need of and the urine protein and sugar in every checkup, and USG, other USG blood sugar and indirect test, Rh negative mother, previous born, and you do the indirect previous liver, indirect test, whether there is the maternal antibodies for this. Yeah, but these are the special tests. Special tests you will do according to the situation. And What is high-risk pregnancy? That is why I say high-risk pregnancy. Every pregnancy is a potentially risk pregnancy. Every pregnancy. When a patient, everything is there. ডাক্তারবাবু সব কিছু ঠিক আছে, সব কিছু ঠিক আছে, কিন্তু যখন ডেলিভারি হবে, যতক্ষণ না ডেলিভারি হয় ততক্ষণ তো আশ্বস্ত নেই। আপনার এখন পর্যন্ত সব ঠিক আছে, কারণ ডেলিভারি টাইম ইজ এ ভেরি ক্রিটিক্যাল টাইম। এনি টাইম দেয়ার মে বি দ্য postpartum hemorrhage, any time there may be the due to hypertension, convulsion. That is the concept of the emergency obstetric care. You will have to ready also there, not only depending on the antenatal care. Modern obstetrics management is the emergency obstetric care. But some pregnancies are complicated with some. There is pregnancy complicated with some factors which may adversely affected on the organ. Suppose either the woman or the baby, these are called high-risk pregnancy. Suppose she has hypertension from the very beginning, from the hypertension, blood sugar very beginning, prior cesarean section very beginning, or placentopivia I have diagnosed. So these are the some factor adversely affect. I will be prepared. My health sector will be prepared to manage those things. So high-risk pregnancy is short note. What is high-risk pregnancy? And give the example. One is the elderly and teenage pregnancy. At the beginning I will say, elderly some complication, elderly there may be hypertension, maybe diabetes, maybe uterine fibroid, and maybe there is a chance of the delayed liver, abnormal uterine action. And teenage pregnancy also there is the anemia. She doesn't know the many. Anemia, one important cause anemia, defective delivery, and chance of preeclampsia also. And is the bad obstetric history. Suppose one last pregnancy there is a stillborn baby, there is a childbirth baby, or there is a difficult delivery, that is the bad obstetric. They will come in what the different bad obstetric history. There is a bad obstetric history. And history of AP is hypertension, preeclampsia, and anemia. Anemia is the important problem is in our country for the maternal anemia. And medical disorder, diabetes, heart disease, renal disease, prior cirrhosis. These are the example of the high-risk pregnancy. Every slides I will be showing, every slides are for questions for you. You must know that. And now bad obstetric history, risk of the unexplained stillbirth. Suppose there is not 30 weeks have come, suddenly 37, 38 weeks, there is a fetal death. Unexplained, you do not know, but there are some causes unexplained. There may be the diabetes properly not, so one of the important causes is the diabetes properly not diagnosed. And there may be the cholestasis is the unexplained death. And there are so many unexplained deaths that we have not revealed at that pregnancy. So you have to be very careful that at the 38 weeks, the previous pregnancy or the mother or the fetus was death. So I have to be careful will prevent, because you can deliver the mother also after 37 weeks the maturity occurs. And the mode of delivery and suppose it's a vaginal delivery or it's a cesarean section. If there is cesarean section, what is the reason of the cesarean section? You have to detail. And if there is a prolonged labor, suppose there is a prolonged labor, difficult delivery, and home delivery, that is the prolonged labor, there is the obstructed labor, and birth of the aspirated baby. Aspirated baby there causes the neonatal death, and delivery vaginal, instrumental vaginal delivery. There is a problem. And there is increased chance of fetal growth restriction. If the mother says, মা বলবে যে আমার বাচ্চার আগের বাচ্চা ম্যাডাম খুব ছোট বাচ্চা হয়েছিল, 2.5 কিলো 2 কিলোর মতো বাচ্চা হয়েছিল, 2 কিলোর মতো বাচ্চা হলো, বাচ্চাটা বাড়েনি, তো ইউ উইল বি ভেরি কসাস যে এই বাচ্চাটাও কিন্তু প্রবাবিলিটি থাকতে পারে, নিশ্চয়ই যে কারণ আছে হিডিং কজ আমরা খুঁজে পাইনি তখন, সেই জন্য এবারে কসাস তোমাকে সেভাবে ম্যানেজ করতে হবে, সেভাবে তো ডেলিভারি করতে হবে, সেই জন্য যে বাচ্চাটা যেন গ্রোথ রেস্ট্রিকশন না হয়। So these are the high risk cases. A bad obstetric cases. And what are the procedures conducted in the first antenatal visit? I have already said. Procedures is the detailed history taking, already said, and the physical examination, obstetrical examination, routine laboratory. I think in the meantime, all of you know these things. Now, in subsequent visit, everything you will have to know. Some of the history will take. History will take. Additional complaints or complication to record the quickening. মাদার বলছে যে আমার বাচ্চাটা নড়ছে, ইউজুয়ালি রিপোর্ট কুইকেনিং কখন হয়? কুইকেনিং নর্মালি কখন হয়? কুইকেনিং হয় 18 উইকসের ক্ষেত্রে, মাল্টিদের ক্ষেত্রে আগে হয়, প্রাইমেদের ক্ষেত্রে একটু পরে হয় 18 to 20 উইকসে। মাল্টিদের ক্ষেত্রে ওটা আগে হয়ে যাবে, দেওয়ার একাস্টার যে প্রাইমেদের ক্ষেত্রে 18 to 20, বাচ্চা আবার নড়ছে, পেশেন্ট বুঝতে পারবে যে বাচ্চাটা পেশেন্ট। উই ডু নট সে নাও দ্য pregnant mother the patient, we say the pregnant mother or woman. She is not patient, she is the physiological person. Physiological process. And physical examination, weight and pallor and edema, apparent BP, and I have already said routinely you will do the urine test, weight and urine test. And any abnormal symptom, patient আমাকে বলছে যে হেডেক হচ্ছে, পেশেন্ট বলছে যে এপিগ্যাস্ট্রিয়াম পেন হচ্ছে, পেশেন্ট হঠাৎ বললো যে আবার ব্লিডিং হচ্ছে, all are very adverse sign, ominous sign, because if there is a headache, if there is vomiting, upper abdominal pain, that may due to the severe preeclampsia, that may be the severe pain, or pain হচ্ছে হঠাৎ বললো যে অ্যাবডোমেন আমার এখানটাতে খুব বেশি পেন হচ্ছে, intolerable pain, that may be the abdominal placenta or onset of the labor also. And any abnormal symptom sign or obstetric examinations finding in each visit you will show the obstetrical examination. And this is actually you will write in your history taking that you will see that I am going into the bile, nutrition, anemia, bile, nutrition, height, weight, edema, anemia, cyanosis, jaundice, and tongue to gum tonsils, neck veins, neck gland, pulse, respiration, temperature. This is a routine checkup. Routine checkup particularly first one, and also for the exam. And as a student, I will give you the stress on this thing, the clinical thing. And systemic examination. Systemic examination, the cardiovascular examination, respiratory system examination, GI system, examination of the other systems. In OPD, when the patient is obstetric, you can see. But you will ask me, sir, পরীক্ষার সময় আমি এত তাড়াতাড়ি কি করে করব? But you just quickly you see, state over the chest, and patient ask the patient is there any problem or not. This is the components of the physical examination. Height, what is the effect of the height? তুমি দেখো height of the sister and height of the patient. Height of the patient, usually the 4 feet 7 inches, 147 inches below, there is a short height. Usually if the short height mother has a small baby, no problem, physiological small baby. But if the baby is larger, larger size, there is obstructed labor, there will be difficult delivery, and standard is the 140 centimeter. Some particularly developed country and other country where there is a height is, it is said that there is the 145 centimeter. Weight, this is a very important question for me. Weight, BMI, I think you must know in all subjects, only in the obstetrics. BMI means where the weight in kg and height in square centimeter. BMI underweight, that is 18.5, below 18. Healthy up to 24.9, overweight up to 29.9, obesity more than 30, and morbid obesity after 35, morbid obesity. And India is now epidemic of obesity. You can see in India, in BMI of more than 25, overweight 24%. The recent National Family Health Survey 5, recent, about 24%. So that is the important advice, my advice for everyone. That is the maintain the health, and balanced diet. The fast food is very dangerous, and also avoid the sedentary habit, always walking, cycling or like that. And next is the edema. Edema, how do you see? Edema, how do you see? How will you see edema? That is, I will go quickly, I cause. These are not the critical antenatal care. You will see. You see, that is just above the medial malleolus, 15 second edema. Just and OPD, you will see how to see the edema. And then you see the pitting edema. You can see. Is it visible? Is it visible? There is the pitting edema. And edema other sides also you will see that the anterior surface of the rods of the cin bone dorsum of the feet, sacrum, parietes over the vulva. If you and this is the vulval edema during pregnancy. It may be normal. Edema sometimes is a normal physiological edema. But if there is a edema, you already exclude the preeclampsia. Preeclampsia. For preeclampsia diagnosis, edema is not included. Previously it was included. But if there is edema, you see whether the hypertension or not. Anemia, I think all of you know. Anemia, where will you see anemia? Anyone? Anemia? Lower palpable conjunctiva. Ask the patient to look above and you will tell lower palpable conjunctiva. And other places, that is the dorsum of the tips of palate nail will. It will do in routine in antenatal care, antenatal checkup, and demonstration of the palate. And jaundice is the upper valval conjunctiva. Ask the patient to look at the floor. Ask the patient to look at the floor. And always in the sunlight. Always. Jaundice is always in the sunlight, in the window. That is, I give you this picture. There is the window. Where is the window? And measurement of the BP. That is very important measurement of the BP. Measurement of the BP is usually taken in the there are semi-recumbent position at an angle of 30 degree, the single left lateral tilt, and or the sitting posture or the sitting posture. Patient will be cool and calm. Patient will be cool and calm. And corrective with the K5 side, K5 is regarded as the diastolic pressure in obstetrics pressure. But in all other cases is the K4 diastolic, the K5. So important question, why the K5? You will answer the question next day. You answer the question, why K5 not K4? And the measurement of BP, so that you see, that is in the book. You see the mother is mild. His mother is mild. And obstetric examination of the breast, usually if the patient complains, you will see, but routinely should be done. And always any male candidate will see the breast in presence of the female attendant. And the pregnancy changes, it has areola, discharge is like that. And obstetric examination, that is the other than the breast, inspection, palpation, auscultation, vaginal inspection. In vaginal examination, routinely the PV examination is not done. Usually done at the first trimester to take the pap smear, size of the uterus, and the last when there will be pain or you suspect we should do for the engagement at the time, the near date, you can do the PV examination. On a daily, on all the, you should not give the examination. Now I think all of you know, this is your clinical part. The right side of the patient is the female attendant. After the evacuation of the bladder, that will be routine. I take the permission after the evacuation of the bladder. And inspection, palpation, auscultation. That is the inspection, inspectory finding. That is the shape of the abdomen, fundus, suprapubic region, any scarma, PVS section or any scarma. You see. And then the linea nigra. This is the linea nigra, striatum. Palpation, height of the fundus. Height of the fundus, symphysiofundal height, abdominal circumference, and the four grapes. This is of important part in clinical examination. In bedside clinics, you must learn this thing before appearing in exam. What to see in abdomen? The lie, presentation, engagement, attitude, size of the baby, and amniotic fluid. So what will you see? And size of the baby and amniotic fluid, you just assess. Amniotic fluid is actually, the amniotic fluid measurement is done by the ultrasonography in the ultrasonography. That is the pocket. Ultrasonography is better, but you can, clinical you can see the, and the height of the fundus, I am just going through. That is the height of the fundus in weeks of gestation. I am not going into detail. That considering the umbilicus is the 24 weeks, the three segments are division, 36 weeks, 37 weeks of term, and 28 weeks. This is the clinical examination. You can, if there is the gross abnormality, suppose the patient has period of gestation, the period of amenorrhea 32 weeks, you will see the 24 weeks. That is maybe the one important cause is the growth restriction. And also there may be growth restriction like a less, and also the wrong LMP, then you will see, trace the first trimester ultrasonography. What is actually the gestational leave. And symptoms of fundal and this is the abdominal circumference, the Leopold maneuver, obstetric grief. And every one of you must know the Leopold maneuver. First Leopold, second Leopold, third Leopold, fourth Leopold. First Leopold is the fundal grief, second Leopold is the lateral grief, and third Leopold is the polyp grief, and fourth Leopold is the another pelvic grief. There is another pelvic grief, fourth Leopold. And what are the findings? What is the you can get the Leopold? And this is the first Leopold, second Leopold, third Leopold, and fourth Leopold. The first Leopold, second Leopold, and the polyp, the third Leopold, and fourth Leopold. And auscultation of the fetal ultrasound. During auscultation, you always palpate the maternal radial pulse. Because during auscultation here, what is the hair also are? And uterine artery. The uterine corresponds to the maternal pulse. So you may mistake sometimes the uterine artery, the fetal ultrasound patient. Suppose what happens, you are seeing the fetal, saying with the stethoscope, and sir, the fetal ultrasound is there. But you, after cesarean section, you see there the fetal ultrasound, baby is dead. What you have done mistake? You have ausculted the uterine sound, the common, that is the uterine artery sound. Uterine artery pulses and it will also. So always, because the almost double, 140 per minute fetal, and maternal is the 70 to 80 like that. And always you palpate. Maternal may be tachycardia. You palpate whether it corresponds or not. That is very important thing. And vaginal examination, like I have already said, late in pregnancy usually done, or patient comes with the better is the early onset of the labor. And routine advices during pregnancy, routine advices. There is the rest, work, travel, exercise, diet, smoking, alcohol. Alcohol and smoking is contraindicated during pregnancy because there is a effect on the mother, effect on the baby, alcohol and smoking. Care of the bowel, dental hygiene, other hygiene like bathing and cleansing, you will give advice. And care of the breast, sexual intercourse, care of the minor ailment. There are some minor ailments I am showing you. Medication and immunization, advice to attend in clinic regularly. And awareness of the alarming signs and to attend the hospital. Alarming sign, the last slide I will show, I am saying, show what are the alarming signs, the mother will come to the hospital facility. To educate regarding the pregnancy, labor, baby care, lactation and family. That is the counseling is very important. And regarding the intercourse, usually the intercourse in the first trimester, intercourse should be avoided. And also if there is suppose the threatened abortion or there is complication, intercourse is avoided. Otherwise during pregnancy, intercourse is not totally contraindicated, intercourse. And minor ailments in pregnancy, that is these are the minor ailments. After pregnancy, minor ailment, this happens, not the physiological, but sometimes may be aggravated. Nausea, vomiting, morning sickness. It's sokale patient morning sickness, and he will be depressed also. This is common. And urinary frequency of the micturition. Fatigue or desire or excessive sleep, heartburn, constipation, backache and pelvic pain, leg cramps, varicose veins, piles, gamma pressure, gum bleeding. These are common during pregnancy. You will have to treat, you will get the symptomatic treatment, and also exclude if there is any underlying. Suppose the excessive blood bleeding, you will see their coagulation profile will do, excessive bleeding or like that. And the vomiting, if there is excessive vomiting, hyperemesis gravidae. Sometimes in hyperemesis gravidae, patient may need to be admitted in the hospital. Hyperemesis gravidae. So management will be like that. And leg cramp is also common. Ask the patient to water with salt and plenty of water with salt. And the leg cramp is the common. And this is about the rest. Is the rest common? The 8 hours night sleep and 2 hours day sleep. And in unconfirmed pregnancy, the patient will ask whether you will take the leave or you will take the leave. in either taking no taking of the leave. In uncompleted pregnancy can go, she can go to the so for what? But what happened? The prolonged standing, severe physical strain, undue fatigue should be avoided. Should be avoided. That is the working woman advice. Working woman. This is another chapter. The advice of the working women. And which drugs and immunization are routinely given in pregnancy? Which drug? That is the iron and folic acid, calcium, deworming. Iron, folic acid is must. These are the routine. Iron, folic acid is must. Iron when you will start? From the when? 14 days you will start. And the total you will give 180 days, iron, folic acid. Anemia mukt bharat. And calcium will also the 14 to 16 weeks. But India, in all country, calcium is all recommended. But India, women are calcium deficient. That is why calcium is given 500 milligram a day. Deworming. There is the anemia mukt form, deworming, albendazole, not in the first trimester. In the second trimester only. And TD vaccine. Now the vaccine which is given, the tetanus and adult diphtheria. Now previously it was given only tetanus, about tetanus and diphtheria. And other immunization as required, not always. So important thing is the iron, folic acid, 6 months during antenatal period and 6 months after the antenatal period. At 6 months. Now it has been extended. In our time it was the 100 days. But India, the anemia is the important cause of the maternal death, the underlying cause, the indirect cause of the anemia. So that is that. And calcium you will give also. And deworming. Just albendazole 400 milligram after first trimester, not in the first trimester. And you must give after the first trimester. And vaccine is the common vaccine is the given tetanus and adult diphtheria. And daily IFA tablet starting from the 4th month of pregnancy and continued throughout pregnancy, minimum 180 days, and to be continued after the postmortem. That is the Government of India Anemia Mukt Bharat 2018. And each tablet contains 60 milligram iron and 500 microgram folic acid, sugar coated and red color. Now daily requirement of the calorie and the individual nutrient. In non-pregnant it is 2200. In pregnant more 300, or 2500. And lactating women 2000. You will remember this thing for your question exam. And this is actually, if you say the patient how much you will take, you will take in pregnancy 300 milligram calorie. Well, how you will understand? You will have to give a daily chart, actually daily pregnancy chart. The nutrition chart is there. This food you will take, you will get this. Because highest calorie is the fat. Next and the protein and carbohydrate is almost equal. This is the make a diet chart for Indian women, pregnant women. And kilocalorie, this is the protein, fat and carbohydrate, these are also needed, the vitamins are also needed. And the make a diet chart for Indian pregnant, you will see the book. You see the book, try to remember this, you see the book. And vaccination during pregnancy, there is one important topic. I have already said, the most of the vaccines during pregnancy should be given according to the risk-benefit ratio. According to the risk and benefit ratio. All vaccines, there are 3 things. One is the vaccine you must give. One, the vaccines normally cannot be given, but risk-benefit ratio will give. And some are totally contraindicated. You cannot give that vaccine. Some are, you see, attenuated live vaccines, general attenuated live vaccines are contraindicated. And the clearly contraindicated vaccine, MMR vaccine, rubella, mumps, measles, mumps, you cannot give. And the chickenpox vaccine, but suppose one mother has exposed to her born sister has come from the hostel with chickenpox, and his elder sister is in the home with chickenpox. What she will do? You will have to, if they exposed, you will give the immunoglobulin, not the vaccine. Immunoglobulin, that will be immunoglobulin you will have to give. This is the common thing. And also live attenuated influenza vaccine you cannot give. And the HPV vaccine, BCG vaccine you cannot give. So these are the contraindications which vaccines you will not give. But clearly indicated vaccine you must give, that is the tetanus vaccine, diphtheria vaccine, These are two, and pertussis also an inactivated influenza vaccine. Government of India, universal immunization program. Who can say which vaccine is recommended? Government of India, United pediatrics question. Mother, which vaccine is recommended? Anyone say? Kide? Well, আমি শুধু বলে গেলে হবে না, তোদের তো জানতে হবে। UIP, tetanus is common, but now it is the TD vaccine is given. Tetanus and diphtheria. Now the vaccine which is available in the government supply, the TD, not tetanus only. TD vaccine. And in some country and also India available, the Tdap, I have said the diphtheria, Tdap. Tdap is available. Tdap is available in outside, not in the government sector. Tdap for the single dose after 26 weeks will give. But TD vaccine you will give as early as possible, as second after 4 to 6 weeks. And you can give also booster dose. You can after. So these are the important vaccine. Tetanus vaccine, diphtheria and pertussis, and inactivated. That is the inactivated. You see here the live attenuated influenza. Any live vaccine is contraindicated, but influenza vaccine you will give the inactivated. A TD vaccine. You see the TD vaccine. There is a TD vaccine, that is the tetanus and diphtheria has been introduced instead of only tetanus oxide. And TD1 is given early in pregnancy and TD2 after 4 weeks. And TD booster is given if pregnant woman has received 2 tetanus toxoid or TD doses in pregnancy within last 3 years. And Tdap vaccine I have said, Tdap vaccine has come newly by SUG guideline and it is also available in India. Tdap instead of TD you can give the Tdap. When it is given 27 to 36 weeks, 20 onward, and that will protect the newborn from the whooping cough. Whooping cough is really a problem with the newborn. The Tdap vaccine. So if any MCQ or like questions are asked for whooping cough prevention, what will prevent? To give the mother Tdap vaccine, pertussis. And situations, there is the last slide, situation where the pregnant woman will be asked to attend the hospital. It is a common question. Suppose there is a bleeding, sudden bleeding, then what is the leakage of the liquor, there is a white discharge, excessive discharge, now pain abdomen, blurring of vision, headache, epigastric pain. So these are all the things. That is the progressive pain in the abdomen and contraction of the uterus. Particularly in the tongue, there will be pain in the uterus. But pain sometimes the first labor pain, that level may be. There are so many causes of the labor pain, but it may be 2 labor pain. So you will have to exclude. And second, when there is an appearance of the sore drainage of the sudden water level, like a drainage, and also the bleeding per vagina. And suppose the patient is not getting movement. When you always in antenatal checkup, in his advice, you see whether the baby is moving or not. Patient can see perception of movement. And first movement perception is the quickening. That is what is quickening. That is the quickening. And severe headache, vomiting, epigastric pain, blurring of vision, collapse, and convulsion. I think all of you understand that antenatal checkup as far as possible. The clinical aspects I have explained all that. Any question you can ask me. Any question. Either you ask me now or later on you can question. Any question.